Literally seems like forever since I introduced myself to you, for those of you that didn't know me. I think I was supposed to have interacted with you several times for vital signs by now. So here's our first day together. For those of you who didn't hear, I apologize for starting class late. I had thought that coming by a quarter after 2 to deal with, are you from IT?
Yep.
Yes. I thought coming at a quarter after to deal with IT stuff would be enough time to figure it all out, but dead batteries, and he's here to help me get a video playing for later. So give us a moment. If you did not get an activity packet, get an activity packet. Okay. So while he's working on this, just a little reminder, I think on the syllabus it has that for me, and I'll be teaching you a lot more this semester after today, that my office hours are by appointment only, and it's just sort of because between teaching in different courses that are not on a regular schedule and trying to get a practice site set up, I don't have a regular schedule. I'm in room 235. You are always welcome to just stop by. You run the risk of me not being there, and even if my door is cracked, it doesn't mean I'll be back anytime soon. You also run the risk of me saying, I would love to talk to you, but it sounds like what we need to talk about I don't have time to deal with at the moment if you do a drop-by. So I'm cool with drop-bys, but know that if you really need to meet with me, like you want to talk about the class, don't understand concepts, if you want to talk about career planning, if you just want to have a chit-chat, but you want to make sure it happens, then the best option is to email me in advance so we can pick a time, and then I block it on my calendar and it's protected. So it's kind of a little FYI. In the meantime, we're still working on sound, and we'll get started as soon as we can. Okay, so the end solution there was we can't get the audio working. So later on, we'll have an activity that we have to modify, or we'll figure it out. I don't know. But in the meantime, we are here today to talk about the medical record and SOAP notes as well. So really documentation systems, where and how you find information about patients. Who has personally worked with medical records before? So not many, only a couple of you. So that's good to know. Who has worked in a pharmacy and is at least familiar with pharmacy systems and pharmacy profiles? About half. All right, gives me a little sense. So, let's see, this part's working. Probably not either. Nope. Yay. So, these are the objectives for basically the activities today, as well as when you do have the exam, which is now next Wednesday. So basically, I want you guys to be able to kind of know what are potential sources of medical information. So where can you find medical information about patients, and based on what you need to find out, what's the quickest avenue? It's not always the patient. Next, know what type of information belongs to different categories. And that might be a bit of a review for some of you. It'll be a bit of a review from lab last year. We're going to talk about the difference between comprehensive versus problem-focused medical histories and notes. We're going to review JACO unallowed abbreviations, because that's a big deal, and talk about what that is. And we are going to talk some more about drug-related problems. They were introduced, I think, in lab last year. I know Dr. Kapp has started to mention the categories of drug-related problems so far in this course, but we'll work a little bit more with those. And then finally, the hope is that you're going to be able to rewrite medical information into a SOAP note. Now, one of the main active learning activities for today, to practice that, involve the video. That's not working. But the good news is you don't have to write a SOAP note on the exam next week. That's something that will come into play, later on in the semester. So worst case scenario, we'll kind of do a workaround with getting out of class maybe a little early, have some homework, and maybe I can steal 10 minutes from a lecture to go over answers and stuff later on. We'll just play it by ear. So with that in mind, I do want to start just with a brainstorm about sources of medical information. So in your activity packet, you should be able to flip to page 3 of that packet. And basically what it's going to ask you to do is take a minute to individually think about what are all the potential sources of medical information out there. Where can you find medical information about patients? From whom, where you can find them, etc. So take a minute to do that, then time it. And then after that, take a minute to talk to your buddies, and then we'll talk to the learners. Just write down as many as you can brainstorming. You need a packet? Yeah. Anyone else need a packet? All right, your first minute is up. So now share with your friends, see if your lists are the same. What did others think about that you didn't?
I had patient, family, doctor, pharmacy records, medical records, past medical history. That's where would you get that? Like,
Well, it depends on the system you're in. So, like in the hospital.
I was like, oh wait, that little USB thing's the receiver.
So like in the hospital, we have a past medical history section, like where they come into the hospital, they have an admission note.
so that'd be part of the
and then
hospital records.
Yeah,
Okay.
hospital records. Yeah.
Okay.
And then, I just kind of wrote down the hospital records of past medical history, prior admissions, admission assessment, nurse and doctor orders, providers, patient handling.
Yeah, I kind of just went with medical records just because I don't know all the
And
difference.
pharmacy records are pretty good.
All right, this is your 5 to 10 second warning. Alrighty. So everyone's had some time. See someone, don't make me point and learn names. I'll do that next year. Yeah. I'll learn this slowly. But so someone tell me, other than the patient, patient is an obvious one. That one's really easy. So what other sources other than patient do people think about, and why? How could they be helpful? Someone volunteer.
Pharmacy records.
So pharmacy records. So what can pharmacy records tell us? What medications are on? What else can they tell us? Allergies?
Mm-hmm.
What information about medications come from pharmacy records? Frequency. So frequency, so not just what medications, but a pharmacy dispensing record is going to have dosage forms, dosage instructions. Is it going to have dates the patient picked up?
Mm-hmm.
So sometimes people learn a lot about patient adherence to medications from pharmacy records. If we maintain a profile like we're supposed to by law, it should also have key past medical history, things like that. Are pharmacy dispensing records always accurate? No. And I think that's the big thing that you have to remember. They're only as accurate as what's entered. So it's not going to reflect medications that a patient is getting from a different pharmacy, from a friend, using them like they're not supposed to, samples from a doctor, over-the-counter medications, or more importantly, the dosing isn't always right. Maybe someone's doctor says start taking 2 pills instead of 1. But your pharmacy system still says 1. And for those of you that have worked with text, that can create the annoyance of insurance now thinks it's a refill too soon and you gotta get a new prescription. So keep in mind, pharmacy records are good sources of information, but they're not the only source of medication information, and you can't rely on them solely. All right, what else do we have? Insurance company records, right. So when things get billed to insurance, whether it's for medications or for medical services, we can get information from that if we're in a position to be able to query those databases. So again, you know what medications have been paid for. So perhaps if someone's using multiple pharmacies but always going through their insurance, you might get a better picture of drugs that they're picking up. On the medical side, there will be ICD-9 codes, which are basically diagnosis codes for patients. So you can identify different past medical history and disease states. So there's a lot that can come out of insurance records. Other sources in the back.
Another way of finding out about medications, the very specific ones are state databases for controlled substance.
Yeah, so there are some state databases. So state databases for controlled substances for sure. Pseudoephedrine over the counter. Think about that. We have to record those sales. Some states have vaccine registries, so patients' information gets input about vaccines. Other sources. School clinics, they maintain records. So for children, I didn't even think about that one, Andy. But for kids, so again, vaccine records, things like that. Huge hot topic with the whole measles thing going on right now. So you've got school records. And other ideas. We've said, okay, I was like, I know we haven't said everything on everyone's list. Yeah, so just the patient's, physician's records. So the medical record maintained by a physician. Medical records in hospitals. Lots of information there. Is that the same one? All right, medical alert devices. So we may, are you talking about like bracelets, things like, yeah. So someone that may not be able to speak for themselves, they may have a bracelet or a necklace with information. One of the things that has been promoted is for patients to keep like an empty prescription vial in the refrigerator with critical medical information. Paramedics are actually taught to look in that location so that if they find someone unconscious in a home, they can see what their medical history and medications are by finding that source of information in the refrigerator in a closed bottle. Not everyone promotes that, but it's done.
My phone came with an app that I'm supposed to fill out with all my medical history so that if I had an emergency, they could check my phone and it would be
All
right
right,
there.
so she was saying her cell phone has an app that you can put all your medical history in cell phone, so computer records. Does anyone else think of any sources on their list that weren't written records?
Family members or
Yeah, family members, caregivers, etc. And sometimes they're in a better position to give you history about a patient than the patient is, especially if the patient has any cognitive difficulties, memory issues. English is not their first language, and there's a family member that is better to interpret, although in general, in more serious situations, it's always recommended to use a licensed professional interpreter, not a family member, because they may actually not be translating the medical information correctly. So I think that's a good starting list. These are some of mine that I kind of came up with as the most common. I think we hit on most of them. So we talked about patient. I separated out family members from caregivers. Sometimes a caregiver is a family member, but sometimes it's a friend. Sometimes it's a hired agency or a hired aide. We talked about medical records. Separate from medical records, especially when you get to hospitals, are nursing records. So nurses may keep their own records. For example, a lot of times it's the nursing record that you see all the patient's vital signs and blood sugars and things like that. We hit, I think, everything else, other providers, pharmacy records, and third-party payers. There is a second type of pharmacy record that we didn't talk about. We talked about dispensing records. That can be hospital-based or community-based. But who's heard of the medication administration record? Show of hands, anyone? A couple of you. So we're going to talk about those a little bit later. But medication administration records are what are used when a patient is usually in a hospital or long-term care facility or perhaps like a methadone clinic where stuff has to be dispensed, or a TB clinic where a tertiary person or a secondary person, a nurse, a doctor, they actually administer a medication to the patient and then document that they did it. So it becomes a little bit more of a certifiable verification that someone ingested a medication versus them just saying, I take it. Because I don't care how much someone tells you, I take my medicines, they might not take their medicines. So.
You're having audio?
Yes, we were trying to play a video and it wasn't working. So you came to check it out too, hey?
Oh, they sent somebody else.
Oh, they did
too?
send someone else, and he played around with it for like 10 minutes, so we gave up.
Huh.
We'll talk a little more while he decides to try. So with that, so that's, think about all these sources of medical information, and again, quickly and accurately, it's probably easier to get a past medical history sometimes from a medical record than the patient if they're like hemming and hawing. Might be easier, sometimes it's nice to start with a printed medication list and then work from there and supplement information from the patient. Again, if someone has cognitive difficulties, learning disabilities, or dementia, talking to a caregiver or family member is probably a quicker, easier source of information than the patient themselves, even though you don't want to ignore it. So with that, we're going to move on to talking about elements of the medical history itself. And on Blackboard, I have 2 supplemental documents posted for you. One is called a guide to history taking, and the other one is tips for symptom analysis. You were exposed to symptom analysis in lab last year. We'll go over it a little bit more. And those are actually documents that I modified from what we had at Maryland and we use with our students. They've existed for like 20 years and they're great, so those are their supplements. But basically, it's important to understand each of these aspects of a medical history because later on, when we talk about more comprehensive notes, a lot of times when you see people document, they will separate their history that they document into separate sections with these headings. So it's important to know what they mean. Chief complaint, you guys should be familiar with, right? Talked about chief complaints in lab last year. Or are we going to try again?
I just want to check this before I.
Well, I'll just talk about chief complaint while he's playing. So keep in mind, chief complaints, yay!
Maybe what
The video itself. Well, he wasn't even getting, when he was adjusting like the volume here, he wasn't getting the little ding.
Yeah,
Still there, it wasn't work. I don't know what you did, but.
I don't know what I did nothing.
Gremlins! Thank you.
Sure.
Gotta love gremlins. Yay! Okay. So again, chief complaints are it's just quickly, why is the patient there? We call it a complaint because usually it's a complaint in the patient's own words. However, know that sometimes there is not a chief complaint. The last one down there, I'm here to get my warfarin level checked. I worked in a Coumadin clinic as my clinical practice at Maryland. Usually 99% of the time when our patients came for appointments with us, they did not have a complaint. They weren't feeling bad. They were just, you told me I had to be here. So I'm here. So the chief complaint, if there's not an actual symptom that the patient is bothered by most that day, it oftentimes will just be the reason for the visit. So that's what that part is. The other thing that hopefully you're somewhat familiar with, really? Oh, I know why. Haha. Okay. The other thing that you hopefully should be somewhat familiar with is history of present illness. Because a lot of this involves a symptom analysis. That if there is a chief complaint, that's a symptom. I'm having pain, I have a headache, I'm coughing, I'm stuffed up, I'm sneezing a lot, I can't stop going to the bathroom. That symptom analysis is what kind of expands upon that complaint to get all the details in order to help figure out what's going on. And that's something that you were practiced a little bit in lab last year. So HPI, again, is usually going to be your symptom analysis, and we'll talk about review systems a little bit later, but you may ask some other questions just to make sure you're not missing anything. So it's really expanding upon the story. So what the heck do you do for an HPI in my situation where someone says, well, I'm here because you told me I have to be? In that case, we usually ask questions relative to why they're there. So in a Coumadin clinic appointment, our HPI would be things like, when were they last here? Has anything changed since they were last at clinic? Have they been taking their medication? Have they missed doses? With warfarin, a lot of drugs can interact. You have to be careful with the amount of green leafy vegetables you eat. So we'd ask questions about that. We'd ask questions about side effects of the drug. So that kind of becomes your HPI in the case of someone just saying, I'm here with us. So for symptom analysis, there's a lot of mnemonics out there. The one that you guys are most familiar with, that you went through in lab last year, is PQRSTA. We don't have to go over this in detail because you're smart enough to read on your own.
We didn't do this one.
Didn't?
No.
Oh, you did Scholar, okay.
Yeah.
Well, guess what? I have Scholar here for you as well. But let's talk about how they're different then. And the symptom analysis tip sheet has this. PQRSTA is often I'd say it's the mnemonic most commonly taught within medicine. Not just pharmacy, but medicine in general. Basic thing is, when you look at these mnemonics, they all get to the same information. No single mnemonic is better or worse than another. You can use any of them. So what I always encourage my students to do is try them out in different ways. Try getting a history using PQRSTA. Try next time with Scholar. Just kind of see what works best for you. With PQRSTA, though, the P is a precipitating event or factor. So it's what does the patient thinks going on, or what were they doing when the symptoms started. The Q is the quality, and I don't know why we will say right now the creating PowerPoints on Mac, playing on a PC, I love the formatting issues. But quality is so having the patient describe what the symptoms feel like. So not just pain, but is it sharp? Is it stabbing? Is it dull? Is it achy? Or for a cough, describe your cough. Is it dry and hacking, or are you producing a lot of mucus? Is it constant, or is it triggered by something? The R is for relief factors, and then there's a second R, which is radiation. So what have you tried that makes it better? That could be something non-pharmacologic or pharmacologic. And with radiation, did the symptoms go anywhere? Now that's not going to be relevant for everything. So like coughing, I don't ask people if their cough radiates. But pain, yes. A headache, yes. Things like that. S is severity, and this is really that how bad is the symptom from the patient's perspective. A lot of students, and you're going to learn, you should have had this lecture by now, but you hadn't, but pain scores. Have you been exposed to pain scores yet? No. Okay. There is a validated scale on which you can assess a patient's pain. And it is on a scale from 0 to 10, not 1 to 10, but 0 to 10, with 0 being no pain at all, and 10 being the worst pain imaginable. Not the worst pain you've ever experienced, but the worst pain imaginable. Rate your pain. And that is a validated way to rate pain. Because for an individual patient, their 5 should always be a 5, and a 6 should be worse than a 4. So that's a validated way to do pain. The only other symptom to which that type of scale exists is nausea, of all things. So on a scale of 0 to 10, 0 being no nausea at all, 10 being the worst nausea you can imagine, that 0 to 10 scale is not valid for anything else in the world. I've had students ask their patients, well, how bad is your cough on a scale of 0 to 10? Or how bad is your runny nose on a scale of 0 to 10? No, no, no. How else could you get at severity then? What could you ask a patient? Any ideas? No one? Tired after therapeutics? Yeah, what are your thoughts? So how long it's been happening may get to severity, although that usually falls down on like the temporal relationship. Because it could be that I've been coughing for a year and it doesn't bother me, or I've been coughing for a day and it's driving me nuts. What might be the difference between those two things? Yeah, that's my favorite. If you didn't hear me, how is it affecting your everyday life? Is it keeping you from going to school? Is it keeping you from going to work? Is it keeping you from going to the gym? You know, so sometimes it can be like, well, how is this impacting you in your life and your daily activities? Are you just able to work through it? It's a minor annoyance, or is this really having a heavy impact? So that's a good way to do severity. Temporal relationships then are all these things like, when did it start? Since the time it started, is this symptom constant, or is it on and off? You know, a really severe headache could be worrisome for a bleed in the head, but bleeds in the head don't cause headaches that come and go. They're constant. So if I'm worried that someone could be bleeding in their head because they have a severe headache, I'm going to relax a little if they say, oh yeah, like the headache will be present for an hour and then it goes away for a couple hours and then it comes back. Okay, you're probably not bleeding in your head anymore. So that's a little bit about the constant stuff. And then associated symptoms, you can ask the patient, is there anything else going on, not directly related, but that is happening at the same time? The way this translates into the other mnemonics is, again, these are 3 of them. So Scholar is the one that you guys went over, with S being symptoms, C being characteristics, so that's like the quality part. The history kind of gets to the when did it start, what precipitated it. The onset gets into that temporal relationship equivalent, location, and then the aggravating and remitting factors. So you can see they parallel each other in terms of the information you will extract from the patient. It's just a different way of doing it. For OTC, and you'll learn this next. Wait, you had OTC. Yeah, so Quest Scholar, I think, is what you did in OTC, where Quest is like querying the patient, and you query the patient using Scholar. And then the E is establish if they're appropriate for OTC care and create a plan. WHAM is another one. This is used primarily also for OTC stuff, like who's the patient, what are their symptoms, how long have they been going on, what action, what meds. It's not as, I don't think, overall inclusive. And then this one, the AS method with 2 T's, that's used a lot more in Europe, but you may find it in the literature. And what it does is it just gathers a little bit more demographic information about the patient as well. So age, are they asking the question or having a complaint about themselves or someone else? What medications are they taking? And then you can see the rest, kind of symptoms, timing, remitting factors are sort of similar. So probably in pharmacy, the 2 most common are going to be PQRSTA or Scholar with Quest Scholar. And the reason you were exposed to Quest Scholar is because it fits better for OTC consults because it gathers the other information. So that's a little bit symptom. So questions about symptom analysis? Okay. Moving on. I promise this is going to be the longest stretch of talking, and then there's going to be more activity later. So then we have past medical history. So again, past medical history you can gather, you can find it in a medical record, you can ask the patient, you can ask the caregiver. But basically what we're interested in is major childhood illnesses. I don't need to know about every sniffle. But major childhood illnesses, adult illnesses, hospitalizations, like not just an ER visit, but overnight hospitalization, what happened in major surgeries is what you're generally going to see reported in past medical history. A good past medical history not only includes the problem, but the date of diagnosis or the date that the surgery or hospitalization occurred, if it's known. That being said, I've also seen students go, well, when were you diagnosed with diabetes? Oh, I don't know, 10 years ago? Oh, so do you think it was 1990 or 90? No, so when it's known. All right, medication history. The one we're most interested in is pharmacists. And I was very surprised teaching lab this year to the 3rd years that, we kind of missed it. Apparently this class got a little bit away from medication history in past years. So now that Dr. Kef and Kuhn and I are here, we're going to really emphasize this. A medication history is not as simple as it seems. And what's really interesting is when you compare trained pharmacists with other healthcare professionals and have them gather medication histories, they're almost never the same. Next year, in the fall, you'll be partnered with PA students and you'll visit someone living in a retirement community. The PA students will make a visit first and they'll have a medication history and then you're going to go. The biggest reflection I got from the 3rd year students was, wow, we did not get the same information out of that patient. And usually, the medication history from the pharmacist was more complete and accurate. So these are things you need to think about. In general, when we talk about a medication history, it's not just the drugs, which would include all types of drugs, but usually that's where we will include both allergies as well as severe adverse drug reactions, information about the patient's adherence, who administers the medications. Does someone take it themselves? Do they have a caregiver give it to them? How do they pay for their medications? And where do they get them from? What pharmacy or pharmacies? Do they use samples from a doctor's office? Do they get patient assistance program medications? Do they use mail order? Do they buy from Canada? Do they import from England? I mean, it's important to know. It's also important to have a systematic plan to gather this information. I told my 3rd years, take this slide with you and mark it off. Because when you tell someone what medications do they take prescription medications and that's it. They don't think about OTCs most of the time unless they're well informed. They don't think about herbal supplements. And then they don't think about all the other things that are medications that they just doesn't come to light. So, active prescription medications, active OTC medications. Often as pharmacists, we will include vaccinations as part of a medication history. Although there's going to be another piece of history we talk about, which is health maintenance that can fit there as well. That's why there's the asterisks. But then, along with vitamins, minerals, and supplements, which I don't know why I order them this way, at the bottom, which kind of gets into all that, there's all these other things. Inhalers, patches, medicated creams, eye drops, ear drops, nose sprays, injectables like insulin, infusions like Remicade that they go to the hospital or doctor's office for. And this is where the 3rd year students got so many different things because they had this systematic way of saying, all right, do you use any inhalers? Do you use any eye drops? And the patient would be like, oh yeah. So really think about these are all medications. And then I put these in blue because I think they're even more important, samples. Are there any medications you get as samples from your doctor? And it's also important to kind of know about recently discontinued things. What's recent? Maybe within the last 1 to 3 months. Because knowing why someone discontinued something can give a lot of insight into their future therapy needs. So it's a lot more than just what medications do you take. Usually you start open-ended and then I start closing. Okay, just to make sure I got it all. Did we miss any herbs? Did we miss any vitamins? Did we miss any patches? Make sense? And then for every medication, there is also additional information that as pharmacists we should be gathering. Does the patient know the strength? And of that, how many pills, inhalations, squirts, whatever, do they use at a time? And at what times of day is that? Is it morning? Is it noon? Is it night? Is it bedtime? Documentation becomes important here. I learned from my third years a lot of patients. We did a role play where someone said, yeah, I'm on this blood pressure medicine, but my doctor told me to double up and take 2 a day. And if they asked, they were very clear. I take 2 tablets in the morning, which should get documented as taking 2 tablets QAM. And a lot of people document that as 1 tablet BID. No, that's very different. So is it one, how many at a time? It's a good idea if something requires special administration, so like an inhaler or putting on a patch. Ask the patient to describe how they do it, or if they can show you, have them show you. Make sure they're using it right. If it's an eye or ear drop, make sure you specify which eye, which ear. Do they know what the medication is for? Do they feel like the medication is working for them? Do they think they're experiencing any side effects? How often do they miss doses? We're going to talk about that as part of the adherence. And then again, if they've recently stopped medications, why? And then finally for vaccines, had a lot of students saying, have you had any vaccines lately? Or have you had all your vaccinations? Patients don't know what they're supposed to have. So, learning what should adults should have flu. So did you get a flu shot this year? Since the age of 60, have you ever had a zoster vaccine, also known as the shingles vaccine? Have you ever had a vaccine for pneumonia? So being specific can help. So that's all the information we need about the meds. For allergies, we need to ask about both food and drug allergies, because a lot of drugs actually have food additives in them. And then it's important to ask the further question. My students do great at saying, do you have any allergies? The patient says, yes, I'm allergic to sulfa. And then they never say, well, what happened? Sulfa is usually a true allergy. It's usually a rash. Can't tell you how many people are documented as being allergic to codeine because it makes them a little bit nauseous. It's an adverse drug reaction. I personally am truly anaphylactic to penicillins. You do not want to give me a penicillin. True allergy. However, I am strongly intolerant to a class of medication called phenothiazines, which are things like Phenergan and Compazine, which are for nausea. I'm not allergic to them, but I get a reaction from them that you've learned about in therapeutics now, maybe extrapyramidal or EPS. It's like a Parkinson's type thing. It's a nasty side effect. I really don't want those drugs if I don't have to have them, but if I needed them in a life-threatening situation, I could receive them, unlike penicillin, which could kill me. So that's why it's so important to document the reaction type and then determine as a pharmacist, is this a true allergy or is it an adverse reaction? And then I sometimes have those conversations with patients. I hear what you're saying, that this made you really, really sick. Just know if you were ever in a situation where there really wasn't another choice, you could receive the drug and we can do something to make you feel better. And sometimes that can be good education to provide. And then the final part of the medication history is adherence. And we're going to do this, talk about this in more detail next year in lab. But when you're asking patients about adherence, you don't want to sound paternalistic. You don't want to ask closed-ended questions. You don't want to say, do you take your meds? Things like, hey, you're on a lot of medications. I'm sure that's hard to deal with at times. On an average week, how many times do you think you miss a dose? Or what factors impact your ability to take your medications? Is there anything that comes up in life that just makes it difficult to remember? Or if you're worried about cost, I know you're on a lot of medications. When I look at your co-pays, they're pretty high. What do you do to get around that? Those open-ended questions where it's like kind of expected that maybe the patient's not adherent, you're much more likely to get them saying, yeah, I do miss like a dose on bingo nights, or I have been stretching out my medicines by breaking them in half. So these are just some things to think about when you're asking about adherence that are more likely to get the patient being honest. All right, so that was a lot about medication history. Questions before we move on? All right, a couple more elements of history and then you get to use your brains again. Oh, and this is just something I included. We're not going to go over. These are a lot of reasons that people will be non-adherent to medications. It's not always intentional. Too complex, too costly, they're having side effects, the pharmacist has issues going on, the prescriber has issues going on. I just like the quote at the top from Dr. Everett Koop, which is, drugs don't work in patients who don't take them. And I've had lots of patients I've worked with over the year that are on 4 anti-diabetic medications when they actually only needed 1 that they needed to be adherent to. But they were on 1, they weren't adherent, their doctor assumed they were or asked in a way that the patient said they were, so another one got added, and another one gets added, and another one gets added. All right, I told you that in the book and in the reading I posted for you, talks about, not in the book, sorry, in the reading, talks about a health maintenance history. This is where vaccines would go. Health maintenance is about preventing first disease from occurring. So that's the purpose of vaccines. The other part of that then is health screenings and tests. So things like colonoscopies, mammograms, etc. Again, we're not always, we have certain rules with some of that as pharmacists and others we don't. But that might be part of a health maintenance history. 2 types of history left before review of systems. Family history. With family history, we're really interested in hereditary disease, and we're only interested in knowing about hereditary disease and primary relatives. What does primary relative mean? Anyone know? Parents, siblings, and children. Grandparents, aunts, uncles, and cousins are not primary relatives. So a lot of physicians may collect information, or you may say, my grandmother had cancer, or my grandfather had a heart attack. But when you're looking at genetic linkages and then predicting someone's risk of future disease, the strongest links are only with the primary relatives. So that's really who you want to worry about. It's good to know what's the relationship, what type of illness did they have, if you know what age at onset, and if they did die, age and cause of death. And again, these hereditary diseases, these are things like cancers and cardiovascular disease and lung disease and stuff like that. It doesn't matter to me if mom had shingles. Shingles is not a hereditary disease. I don't need to know mom had shingles. Those types of things. And then finally, we have social history. Social history also has a lot of different things. Some things you'll read that insurance status is social history. We often collect it as part of our medication history to know what kind of medication coverage. But social history is things like tobacco, alcohol, caffeine, illicit drugs. With those, if someone has yes, again, quantify. Not just do you smoke, but well, how much? Or not just do you drink, but how often? How many drinks at a time? Recent travel is sometimes important. Think about the whole Ebola aspect. Recent travel became a very important part of the history if someone came from Africa. Depending on their situation, their type of residence, if this is someone at a high fall risk, do they live in an apartment building that requires them to use a lot of stairs? What's their level of education? That may change how you communicate. With occupation, you're looking for things that might carry occupational hazards for disease, like firefighters, much higher risk of certain cancers and lung diseases because of smoke exposure and chemical exposure. And then economic status can be important. Again, if you're thinking about how are they going to pay for medications, pay for health care. I've done some work on Indian reservations where people didn't have refrigerators. So you can't give the kid an antibiotic suspension that requires refrigeration if they don't have a refrigerator. So that's social. All right, so those are usually almost like the checkbox things that. And then you have the rest of the checkbox form, which is this big thing called review of systems. When you go to a new doctor, you often fill out this big form, and on the form, it has by body system, like your head. Do you suffer from headaches, blank, blank? You know what I'm talking about? That's a review of systems done in paper format to cut down on the work the doctor has to do so that they can only query about the positives. But basically what this is it's a series of questions grouped by organ system. You're going to survey the whole body. Best to go head to toe. But a lot of times we'll just do parts of it. And again, the purpose of this is to either get more information about problems that exist or identify new problems that the patient has no clue about. And I talked about the fact that a targeted review of systems is part of that symptom analysis. So for example, if someone comes in complaining of headaches, I might do a review of system for their whole upper, above the neck system. With these, it can be very tedious. So what I tell students is start with open-ended questions. So start with, are you having any problems with your breathing? If they say no, maybe ask 1 or 2 follow-ups. Okay, to be specific, any coughing, any wheezing? Nope. Okay, move on. Are you having any trouble with your stomach? Okay, to be sure, any, constipation, diarrhea, or pain? So I'm not going to go through the whole detailed review of systems. You have a review of systems guide posted on Blackboard, and it basically has all the potential questions you could ask for each and every body system. So it's something else that, again, if you're interviewing a patient, you can pull that out and use it. But again, do not be tedious. It's best to say any problems with your heart that you know of, any problems with your muscles that you know of, and you kind of start global and go from there. All right. And then kind of finally we get to vital signs, physical examination, and other testing. So when we talk about vital signs, there are now 5 vital signs. You're going to learn a lot more about them from Dr. Keff Monday. Blood pressure, heart rate, respiratory rate, and temperature are the traditional vital signs, but pain score is the new vital sign. Height and weight is important. It's often included with vital signs. You may see people doing a head-to-toe physical exam of the patient. And then you have things like lab testing, so a glucose level or things like that. Or you might have other diagnostic testing, things like EKGs, echoes, stress tests, stuff like that. So that's kind of fills it out. Okay, so now that we've gone over all of this, I guess I'll do that first. What is the difference between a comprehensive and a focused history? And this would then translate to how you document the encounter. Do you document in a very comprehensive manner or a focused manner? So comprehensive histories take a lot of time, 30 to 60 minutes at best. First time a pharmacy student or a medical student does a comprehensive history, it could take 2 hours or more. A comprehensive history is reviewing all of that, everything, whether there's a complaint or not. So it's, physical examination of every body system, a review of systems of every body system, a detailed family history, a detailed social history, everything. So these are typically done when someone establishes outpatient care with a brand new provider, at an annual exam, or upon admission to the hospital. Those are generally the situations where you see the comprehensive history done. You will rarely be in a position as a pharmacist to need to do a comprehensive history. As a pharmacist, you will be doing usually focused histories. Once you get good at it, you can usually do it in about 8 to 15 minutes. I'll say up to 20 if you're going to do a good medication history as well. And it's only getting information that's relevant to the issue at hand. So for example, in my Coumadin clinic, even on an initial patient visit to that clinic, we're concerned with their warfarin. So yes, I got a full medication history, but all I cared about in family history was, is there a family history of clotting? Is there a family history of bleeding? All I cared about in social history was tobacco and alcohol and illicit drugs because and vitamin K in the diet. I didn't care about the rest of their diet, I cared about vitamin K in their diet. So you pick certain pieces that are relevant to what's going on. You pick certain body systems to do and review of systems, and you just focus in. And that's a very difficult skill to learn over time, is what's the important information? And that's something that will get honed through therapeutics, especially once you get to therapeutics 2 and 3, is starting to say, well, what's the information you minimally need to make decisions in this case? But that's a lot of what you'll be doing as a pharmacist. And then if there is any physical examination needed, that's going to be focused as well. So again, if you go in to urgent care, with complaints of potential bronchitis, they're basically listening to your chest and lungs and looking up your nose, and that's it. They're not examining the rest of your body. Okay, so with that in mind, This gets to subjective versus objective data. And I know you've been exposed to this concept, right? Concept. So if you go to activity packet page 4, what you're going to see is a little grid. And what it is it goes through each of these elements of history that we just talked about, and it asks you, is that element of the history subjective? Is it objective? Or could it go either way, kind of depending? Or have you seen it go either way? This becomes important because when we get to writing SOAP notes, which include subjective and objective sections, you need to know where to put the data. So take a couple minutes, work through this on your own, talk to your neighbors. We'll give it like 3 or 4 minutes, and then we'll kind of go over this so that we have a plan for this course as a whole on what's going to be subjective and what's going to be objective. It's HPI, and could that get confused with like stuff about HIPAA? So for HIPAA, it's protected health information, PHI, versus HPI, which is history of carcinoma. So acronyms with the same letters, with one reversal. In case anyone else was wondering, because I thought it was a great question. All right, so let's go over what people thought. So family history. Show of hands for who thought it was subjective. Okay, so I'd say 90% of you are saying subjective. And that is correct. Because remember, for something to be objective, it has to be measurable and verifiable. So first of all, someone saying, my mom has a history of heart disease is certainly not measurable. And unless you are the person taking care of the mother and witnessed her having a heart attack, how is that verifiable? You're really relying on a story. What's important to note, and this is going to be the same of things like chief complaint HPI, past medical history, they fall in social history, they're going to fall into that same realm. Because you're relying on what the patient's telling you. It doesn't matter the source of the information. It doesn't matter if your source of your past medical history or your source of your family history is a medical record at a doctor's office. Just because it's written down doesn't make it objective. It was just subjective data that someone else happened to document, and you're using that as a source to gather the information as opposed to hearing it directly first-handed from the patient. Does that make sense to everybody?
So yes, but just in case I forgot one.
We will.
Family history.
Yeah, we'll go through. Yeah, so
history.
family history is subjective. Chief complaint HPI is subjective. Social history is subjective. Past medical history is subjective. The ones that have history in the name. Okay. Vital signs.
Objective.
I'm hearing objective. Yes, vital signs are objective. What goes with that is also going to be your physical examination findings. Those are also objective. Vitals are part of it. The reason is because it is something that can be measured. I'm measuring a blood pressure. I'm measuring a deep tendon reflex. If I'm listening to someone's lungs, I'm essentially measuring what their lungs sound like. It's kind of a weird definition of measuring, but you're still measuring. What makes it verifiable is that if someone is appropriately trained, multiple people examining the same patient should get the same findings. So when I take a blood pressure and we're listening with the double-headed stethoscope, we should get the same results. If I put my stethoscope on someone's lungs and I hear that they're wheezing, someone else should hear that they're wheezing. So that's what makes it verifiable, is that a trained person with the skill to do so would be able to replicate the physical examination findings. And we have systems and terminology and accepted ways of documenting those findings. All right. Next, allergies. Who thought subjective? A couple brave souls. Who thought objective? Who thought it depends? Okay, so most people thought it depends. So why was this an it depends for you? You're brave.
It may have been an actual allergy, but it may have been something the patient just thought was an allergy. So yes, they could really have that allergy.
Okay.
Or
so what she's
no,
saying
they don't.
is it a true allergy or not, or is it an ADR? Although, what I would challenge is that's an interpretation of the information being given to you. It's not necessarily the information itself.
Could have been observed by a trained medical professional.
Yeah, so if it was observed, that would probably be the only time it would be objective. So, usually an allergy history is just like our past medical history. I'm allergic to X and this is what happens. Or it gets written in the medical record, and then from that medical record or from that pharmacy record, we say they have an allergy to penicillin. But you weren't there. You didn't observe it. You didn't see it happening. And you can never 100% prove that a drug was the cause of the reaction. That's very difficult to do. We can have a very, very 99.999% suspicion, but we can't really prove it. So you could kind of make the argument that it's objective in the sense if someone anaphylaxis in front of you after you give them the vaccine, you watched it happen. That being said, the documentation of a anaphylactic reaction to X vaccine will still medically always go in the subjective section. The physical observation of seeing it happen becomes physical examination. Because part of physical examination is seeing the patient and describing what you're seeing. So in the case of an observed allergic reaction or suspected allergic reaction, the reaction that you observe is actually physical examination data, which is objective. The documentation of a suspicion of an allergy to a drug or a patient report is actually subjective. Does that make sense to people?
What about like a documented allergy test?
Okay, so and she was saying, what about a documented allergy test? So in that case, that becomes part of your laboratory testing. So that a documented allergy test would be objective data because it's laboratory testing.
Alright.
So someone says subjectively, I have an allergy to ragweed, and then you objectively confirm it with allergy testing. Just like someone subjectively says, I have diabetes, and then you objectively confirm it with the hemoglobin A1C level. Okay, let's see. Imaging and diagnostic tests. What do you think?
Objective.
These are objective, as is laboratory testing, for the most part. We have the exception at the bottom. So these are things that you're ordering. You know, you're sending a patient to a lab to get a lipid panel done. You're sending them to get a stress test done. These are being done at facilities that are certified. They have trained personnel performing the blood draws, performing the analyses, doing the exam, and just like physical examination, there's standard nomenclature for how we document and interpret findings. So those are become objective information. It does not include interpretation of what it means. That's an assessment, and we'll talk about that when we get to SOAP notes. It's just the facts. The facts and subjective and objective information is always, these are the facts. What you think about the facts come later. Alrighty, so that takes care of that. Let's go to medications and vaccines. They kind of lump together. So what do people put for medications and vaccines? Who put it depends? Okay. Who put subjective? Who put objective? Okay, so we're about a 50-50 split between it depends and objective, and a much smaller percentage is subjective. The small percentage that went with subjective, you're probably the most right, even though you were the smallest group. So let's talk about this. There's lots of ways to know about medications. Problem is, definitely if all you're doing is querying a patient or a caregiver, or looking at documentation in a medical record of medicines that the doctor thinks the patient's taking, that is subjective information. We already talked about how incomplete data can be. Patient recall of what they're taking and what they're doing is not always accurate. You have no way to verify what's happening. That patient can say, yes, I take this medication every single day, and that does not mean they're ingesting it. What if they have their prescription bottles? Doesn't that mean it's objective? No, it just means they have a prescription bottle. Doesn't mean they're actually taking the medication. You can't verify they ingested it. Where do things start to get fuzzy?
Inpatient.
Yeah, we're going to go to the best example. The best example of objective medication histories is when it's taken from a medication administration record in a hospital, in a nursing home. This is the situation I told you about, where there is an order placed for the patient. That order is usually verified by a pharmacist that it's appropriate for the patient at the appropriate dose. The medication is dispensed. After it's dispensed, it's usually checked by a nurse to make sure it's the right medication and the right dose, and it's being given to the right patient. And then they actually physically administer it to the patient, and unless the patient is in a psych hospital and cheeking it, usually you can guarantee they swallowed it, or they'll document refuse to take. That's clearly an objective medication history because you know exactly what went into the patient. The situation that goes a little,
So isn't the correct answer then it depends? Because
Right.
it does depend.
Yeah,
It's not
it
really
will
subjective.
depend. Yes, sorry. I guess if we'll get to what the correct answers are for this class. But yeah, it depends.
So the depends column is more of it depends where you work, because it
Yeah,
sounds
she's
like a lot
asking
of
the
these
depends column. Yeah, the depends column is depends on terms of it could belong subjectively or objectively, or it could depend on your workplace practices. Another area in medication history that gets fuzzy is pharmacy dispensing records. Your textbook, I believe, the reading I gave you actually say pharmacy dispensing records are objective because they're dispensing records, you know it was dispensed to the patient. I personally still count that as subjective information because just because I dispensed it to the patient doesn't mean they're taking it. So medication history and vaccines go the same way. Documentation of vaccines received versus the patient telling you. This is probably the biggest fuzzy area. We'll get to more, but this is the biggest fuzzy area. So it depends on your practice site, and on the next slide, I'm going to tell you what we're doing in this class. Medication history, where you document it, you got to be flexible. Did that answer your question?
Yeah, just about the vaccines. I don't understand how they'd be subjective if most of the time you're at the doctor's.
Yeah, so she asked how could vaccines be subjective? If you have an actual vaccine administration record that's like a medication administration record, then you know it was given. Usually we're just getting a vaccine history from the patient though. Did you get a flu shot this year? Did you get your pneumonia shot? So it's based on patient recall with no confirmation, no verification. All right.
I guess.
Let's
It
see.
depends.
Pain score.
Subjective.
Yeah, pain score is subjective information. Always. And the reason is because although it's measurable, it's not verifiable between patients. As I said, a 5 to one person is not the same as a 5 to another. Versus me hearing wheezes in the lungs of one person is the same as me hearing wheezes in the lungs of another. So it's subjective information. Where it gets tricky is it's considered a vital sign by the Joint Commission, which credits hospitals. So it gets documented with vital signs in the objective section of notes. So it's a weird one that it's truly subjective information, but it often gets documented with vital signs. And we'll talk about that in a second. Review of systems, just for time's sake, I'll give you a break, that is subjective. This is always you asking the patient, are you having this symptom? If you then do physical examination, so for example, on review of systems, I could ask a patient, are you having leg swelling? And they say yes, that's subjective. If I then examine them and note edema myself, I've objectively on physical exams confirmed that complaint. What about mini mental status exam?
Objective.
It's objective. And I think Dr. Sherwood's kind of gone over that already. Has she? No, not yet in therapeutics. Many mental status exams are objective because you're giving the same exam to everyone. And it's validated. Just FYI, that came up. And then the final one is home blood pressure or blood glucose values. What do people put? I heard it's subjective? We thought it was objective.
What about the ones that record the history and their?
What about the ones that record the history? Okay. So, kind of goes back to like your medication stuff. Technically, if a patient brings in home blood glucose values, home INRs, home blood pressures, it doesn't mean we won't believe them enough to make decisions about care. But technically, it's subjective information. Even if it has a recorded history, do you know that they really tested themselves? Do you know that they used the machine properly? Do you know that the strips weren't out of date and the machine still worked anyways? Do you know that they used the proper size blood pressure cuff? You don't know. You can't verify it. So because it's not verifiable, even though it's measurable, it's subjective. Now, if someone came in and they brought their machine and I helped them do that test, then yes, it's an objective blood glucose value. It's just like taking their blood pressure for them. So it's not the machine itself, but was the machine used in the presence of a trained healthcare professional or not? Does that kind of make sense? Okay. So in summary, as you go down the list, Family history, subjective. Vital signs, objective. Allergies, subjective. Chief complaint HPI, subjective. Imaging diagnostic tests, objective. Social history, subjective. Vaccines, subjective. Did I say vital signs were subjective? No, okay.
You said it depends on vaccines because it depends on where you're getting your information.
Okay, so vaccines, it depends.
That shouldn't be a column.
And for allergies.
Allergies, let's just go ahead and call it subjective, because remember what we said is you could have a physical examination finding of the reaction itself, but you still can't 100% verify the cause. And allergy testing is a lab test.
We should just get rid of this column.
So vaccines are an it depends, lab tests are objective, meds are it depends, past medical history is subjective, pain score is subjective, although it's going to get documented elsewhere. Review of systems is subjective, physical exam is objective, mini mental status is objective, home blood pressure, home blood glucose are subjective because it's a different type of data. So rules for this class. How are we going to deal with the maybes? And then we'll do a break. So, as your reminder, rules for our class. Always document under subjective. If you're writing a SOAP note, we're going to talk about it. Always document under subjective. I don't care if it came from what we decided was an objective source. For ease of lack of confusion, always document under subjective medications. But then put your source. Put from an MAR, from a patient history. Because whether it's subjective or objective, the real reality is what is the nature of the documentation system where you work. Every preceptor you have will want it differently, so this is what we want for the class. Put allergies and vaccines under subjective, insurance information, and the self-monitoring under subjective. In our course, for pain score, put it in the objective section, along with vital signs. If you happen to ask about a pain score as part of your HPI, then just put it in both places. That's just to have clarifications for the course so no one's like, I don't know where to do it. This does not mean that when you get to therapeutics 2, that they won't say put medications in objective. This doesn't mean when you go on your IPI rotation, they won't say put vaccines in objective. You just got to be flexible. Fair enough?
Mm-hmm.
Question? Yeah, I will add afterwards the slides that are missing the information. I'll repost the new set. All right. So let's do, is 5-minute break enough?
No, I have to go to the bathroom.
10-minute break?
Yes.
10-minute break, we will regroup at 3:55.
I need 10 minutes.
We're going to get started. If people come in late, that's fine. So we're going to stick a little bit with medication history stuff, and I'm going to talk a little bit more about MARs, since almost no one has seen one. So I have 2 examples in here. This is an example of an electronic MAR. So this is actually the company that the hospital I worked at part-time in Maryland. We use this. It's Cerner Epic. What you see on the MAR is you see a list of, like, they will organize it by the medications, small. It says scheduled, unscheduled, as needed, and continuous infusions. So the unscheduled would be like one-time doses of stuff. Scheduled would be something that's repetitive, PRN, etc. And then what happens with these electronic MARs, so for example here, this is levofloxacin, it's an IV. It shows that on this day, it says 8:14 at 3 p.m., you can't really tell. That big blue box means that it's due. Patient's due for that dose. Versus when they're given a dose, so up here, this is their digoxin, it was due that day at 2 p.m. Once the nurse gives it, there's usually barcoding systems and everything. It actually puts in and gives the authorization of that the drug was given and verifies it was given. In this case, too, you'll see here it says 78 beats per minute. So some drugs with these EMRs, you can put in parameters that the nurse has to check a blood pressure or a heart rate or something first to make sure it's safe to give. And so that's where it can document it. Or here you see they gave 10 units of insulin, even though it's hard to see because the patient's blood sugar was 201.
What does EMAR stand for?
Oh, sorry. What does EMAR stand for? Electronic Medical Administration Record, as opposed to just Medication Administration Record.
What did you say the name of the software was for this one?
This software is called Cerner, but it doesn't really matter. But this is just an example. Most health systems are going to be going to electronic medical records. This is the kind of thing you'll see. Now, When I was in pharmacy school and did residency, these didn't exist. We had paper forms. And when you're in lab with me next year, you will have paper forms because I don't have access to a fake electronic medical record. But we'll work with these next year. So I wanted to expose you to what it looks like and do a little activity with that. This was taken, you see the Northeastern Hospital at the top because that's what I created for lab. But this was a form that was actually posted online from a hospital, just a blank example, so I stole it. Well, I didn't steal it, I actually recreated it. What you see here, when we were in the world of handwritten marks, usually what happened is each day, any continuing medications the patient was on would print out. And then if something was added later in the day, the nurses would write in the new information, and then the next day it would show up in the printout. So what would happen is you would end up with a nice little alphabetical list of drugs, and then there would be stuff at the bottom added. And you can imagine how many transcription errors and everything else. But usually what these will have is on this one, it has an order date and a DC date. So what date and time was the drug first ordered? And if it was discontinued, what date and time was it discontinued? So this was tricky because in the electronic one, if something is discontinued, it just disappears. But on these old paper ones, it might still look like someone's getting a drug, so you really had to pay close attention to whether it was being administered or not. There's room then for the information about the drug itself, and then over here, a schedule. So the schedule is what times does it due. So for example, just because something is ordered at 7 a.m., that doesn't mean a dose has to be given at 7 a.m. It may be that it's not given until the first administration at 10. The hospital I worked at in Maryland, the way it defaulted is the only way a patient got a first dose immediately is if the doctor wrote first dose now. Otherwise, they didn't receive a dose until the next scheduled administration time, even if that was the next day. So something we had to do as pharmacists, even with electronic prescribing and things, is call them and be like, do you really want to wait till tomorrow for this, or did you mean to write first dose now? There were a couple exceptions, antibiotics, things like that. Then over here, you have places where nurses by date, so different day each column, if it's used over several days, that they can initial if they gave it or not with the time. And then this particular form for those non-recurring medications, so something that's give a single dose of Tylenol, or give a single dose of Ambien to help them sleep, but it's not going to happen over and over, or it's not going to be a standing as needed medication. Those would go at the bottom on this form, just as a, here it is, and here's when it was given. So with that, to get you used to looking at this, this is where we're going to go to our next activity, which is pages 5 and 6. What you have on page 6 is a completed medication administration record, similar to the ones I'll use in lab next semester. What you have on page 5 is a series of 7 questions to answer based on the information there. So this is just to get you used to looking at MARs and kind of start to understand the information. So I'm going to give you guys 10 minutes to get through as much of this as you can. Feel free to talk to your buddies. And then we'll go over the answers and move on to SOAP notes. I do believe most everyone as I walked by at least has answers for most of these, so we'll go through them. Couple things to orient you to, if you didn't notice it already, and I can't really make it that much bigger here, is all of your order dates that started on day 1 started at 2100. So often, people don't just magically appear at the hospital at midnight and start a new cycle. So if you didn't notice that, that's sort of something that was important in here. To notice the patient's orders didn't even become active till 2100, which it also get used to military time if you're going to work in a hospital. So didn't get active until 9 p.m. That night. So you wouldn't expect anything that's due before 9 p.m. to be given that first day because they weren't in the hospital yet. The other thing, if you missed it, and I should have pointed this out, is on the first page it said basically that it's now day 3 at 2 p.m. So anything after 2 p.m. wouldn't be. So with that in mind, the first question was, what scheduled medications didn't get administered to her? So what did people come up with? Alendronate. So right here on this one, and here we'll do this way. We have Alendronate ordered, but it wasn't given because they were trying to confirm the day of the week. This happens a lot. So that one was never given because we didn't know what day of the week, and what if the patient had just taken it the day before? So that one wasn't given. What else wasn't given? There was one other.
Influenza?
Sorry, what? No. So,
Carbinol.
1 dose of carvedilol. Look how tricky this is. It's a lot easier in electronic medical record, but helped. So why might this happen? Well, what you see is in the order, it says to hold for a low systolic blood pressure or
But
a
it
low
was
heart rate.
administered her, just
And that'll
not
be
one
common in
dose.
hospitals. Drugs that can lower blood pressure, drugs that can lower heart rate, drugs that can lower blood sugar. It may be a standing dose, but then you'll be ordered to not give it if it would be dangerous for the patient because their parameters are already low. So that's the other one that wasn't given that was scheduled. Now, if you came up with anything else, it wasn't correct, and it's probably because you didn't notice it had been stopped. So like here, this was stopped on day 2 at 1800. So you wouldn't expect anything after that time. Or for here, this was stopped day 2 at 0700. So again, you wouldn't expect any doses after that time. Okay. Next, how many doses of guaifenesin did the patient get while they were in the hospital?
2.
Everyone yelled out?
2.
2. Yep. So the guaifenesin, hopefully you can see me, it's right here. PRN medication, 2 doses. When was prednisone ordered, and did she get her first dose at the proper time? So first of all, when was it ordered?
7 a.m. day 2.
7 a.m. day 2. So if we scroll down, this is where the nurses were writing things in. Oops. So here's the prednisone ordered at 7 a.m. on day 2. Did she get her first dose at the right time?
Yes.
No. Here's the reason if you didn't pick up on it. It said give the first dose tomorrow.
Hey.
And yet, this was the day 2 column, someone gave a dose. This dose here should never have been given. Probably reason being, she was still getting IV methylprednisolone that day. And they stopped it. They're switching her from IV to PO therapy. So commonly, you don't need to start the oral therapy until the following day. So if you missed that one, they gave a dose early. So that would be a medication error. All right. How many amoxicillin clavulanic tablets should be prescribed to her upon discharge?
16.
16. Did everyone get 16? If you didn't, you probably put 15 or something. So again, the key is that she needs to get 10 days of therapy, but 10 days doesn't mean 10 physical days. It really means 20 doses. So at this point, if she's gotten 4 in the hospital, 20 minus 4 equals 16 tablets remaining. And part of the discharge education would be start this tonight. You got your morning dose here in the hospital. You're going to be taking this twice a day until it's gone. But make sure you take your next tablet when you get home tonight. Fill it at the pharmacy. Don't miss any. All right. Did she get any vaccines?
Yes.
I heard a yes. So if you missed it, this is where vaccine's a one-time thing, non-recurring. So if we scroll all the way to the bottom, we see that we got a vaccine on day 2, our flu vaccine. Okay. She didn't get any nebulizer treatments on day 3. Who's brave enough to try to explain what happened? You talk a lot.
I do.
Anyone else, or I'll let her go? Yay, new person.
It's a PRN, so it's only IV.
Yeah, so it was a PRN medication at that point. So she didn't get any if she didn't need it. So if you have trouble following this, something that happened, this person's admitted for a COPD exacerbation. What you see up here, originally ordered, was actually 2 different ipratropium albuterols. And this can be appropriate, that they're going to get standing doses while awake. And it did say while awake. And so that's why giving the midnight dose and the 4 a.m. dose weren't missed doses, even though they were scheduled. And then they had as needed every 2 hours. It's pretty common when people are having bad lung problems. But they were both stopped in the morning of day 2, at 6 p.m. day 2. And at that point in time, it was changed to just an every 4 hours as needed. So by day 3, it just looks like the patient wasn't needing it anymore. And that's what you would want. You would want them not needing supplemental medication before they go home. So kind of start-stop dates matching them up. And then finally, it said that her doctors planned to write a prescription for Ambien at discharge. She wasn't on it at home before her stay. Do you think that's appropriate or not? What do people think? I heard lots of discussions that went both ways. So how many people said yes, give it to her? Okay, how many people said no? And that means the rest of you were indifferent and didn't make a decision. So in this case, I as a pharmacist would probably say no, and here's why. It's not wrong necessarily, but if you look at this, it was an as-needed medication and she needed a single dose her first night in the hospital, but she didn't even need a dose the second night, and she wasn't having insomnia at home. When patients go into hospitals, we're talking over here, they tend to get a plethora of medications put on their profile as needed so doctors don't get bothered. You will see here on medications for pain, sleep, nausea, constipation, depending on the hospital system, inappropriate initiation of proton pump therapy, like omeprazole, in every single patient, whether they need it or not. That was my hospital. Everyone got, it was actually pantoprazole, drove me nuts. And then the doctors see it on their MAR, whether they're using it or not, so they write a prescription for it when the patient goes home. They don't have GERD, they don't have insomnia, they don't have nausea. So you don't want to see patients getting prescriptions for as-needed hospital medications that were started only because they were in the hospital and that they didn't really use anyways. Now, is there harm in giving her a couple? Perhaps not. Maybe she would have trouble sleeping when she gets home. The flip side of that is this is a 72-year-old. You give her a sedative hypnotic. What if she gets up and falls? So that's just kind of, this is when you identify drug use without indication in your patients on the outpatient side, hospitalizations and not discontinuing hospital meds that weren't needed outside of the hospital situation is probably one of the more common causes of drugs that don't have medication. So I put that in there just to kind of highlight it. So do you feel like you have kind of a general working knowledge of what an MAR, what kind of information you can get from it? Yeah. Yes.
So, what about the fact that she was on steroids?
Oh, okay,
And
yeah.
she's taking a prednisone at 10 o'clock, and elimination of like prednisone is like 4 hours, so it's gonna go off the system by 10 p.m. So
Yeah.
we're not giving her like one pill for that.
Yeah, so his question was about the steroids and with the half-life of IV methylprednisolone, would you want to supplement a dose? Sometimes you need to, sometimes you don't. If someone's clinically doing well with a COPD or asthma exacerbation, you can usually just switch them to daily dosing. And probably this patient would be continued on prednisone at home, things like that. Does that answer your question? Okay, so we're just interpreting data. So we're going to go back then to where we were. All right, so that gets us past our MARs. So then let's talk about what I'll call pharmaceutical care plan development. And then that'll bridge us into SOAP notes for our last 40 minutes or so. So what happens after you get information about a patient? Well, basically, what you're going to do next is you're going to develop a problem list. So someone was raising the issue, what if a patient says they don't use illicit drugs, but clearly they're going through what looks to be symptoms of being high and they have a positive tox screen for cocaine. And that came up as part of the discussion of subjective and objective. And I said, well, subjectively, they denied using illicit drugs. Objectively, they have a tox screen positive for cocaine, or the patient denies that they drink. And you don't want to, like, get on them about it, as Dr. Teeter said, but then they have a blood alcohol level that's elevated. It's subjective and objective data that conflicts. Well, that's where your problem list comes in, because the problem list is, no matter what the patient says, I suspect they're an alcoholic, and during this hospitalization, they might be at risk of going through withdrawal, so I may need to come up with a plan to deal with that should it happen. That's called assessing the patient. So the first thing you're doing is you're developing a problem list. What are the medical problems? What are the drug-related problems? And then you assess and prioritize them. Why do I think it's happening? What's most important to deal with? Do I need to send the patient elsewhere? Like in my case at Coumadin Clinic, if someone came in with acute chest pain, I was calling 911. I wasn't dealing with that. And then for these issues we need to deal with, how do we optimize their treatment? How are we going to monitor it? And then what education do we need to provide to them? And you may pick and choose which of these latter steps happen depending on the situation. You may not educate a patient their first day in a hospital, but then do it when they're going home. So that's kind of like the back half of it. Subjective and objective information are factoids. What you do with those factoids and the judgments you make become the back half of the process. So again, one of the big things is drug-related or medication-related problems. And these have already been reviewed with you, but as a brief thing, untreated indication, meaning we have an indication that isn't being treated. Now, I put in parentheses or here, and I believe it's on your history taking tip or SOAP note tips, additional therapy needed. This is the one where I think, well, someone's on the right drug at the right dose, it's just they need another drug. A lot of people will lump that into untreated indication. I've just always created my own little 9 things. Medication use without indication, so I'm on something and I don't have a reason to be. Subtherapeutic dose, so it's the right drug, but it's just not being dosed appropriately, versus overdose. It's either the right drug, but we're giving too much for one factor or another. Wrong drug selection, that's usually because of a drug interaction or a contraindication. Failure to receive gets to your adherence issues. So someone's not ingesting it for some reason. Adverse drug reaction and drug interaction. On the SOAP note tips document, I think is where this one is, it has potential causes of each of these that you can review on your own later. Like, what are some of the etiologies? And you'll notice that sometimes the etiologies overlap. So, for example, inability to afford a medication could result in both failure to receive medication or subtherapeutic dose if someone's cutting their pills in half. Okay. So just as a quick little exercise, because this is something that will be on the test, is name the drug-related problem given the description. So, I'll post the answers later, but this is just a shout-out. Heart failure patient is taking carvedilol chloride at 12.5 BID. The target dose for this drug in this patient population is 25 milligrams BID. All other drugs in the patient's regimen are appropriate.
Subtherapeutic.
I heard most. We're going to go through these quick. This is a subtherapeutic dose. You're trying to reach a target dose, you're not there yet. Okay, next. Patient was hospitalized in the ICU for pneumonia. She was intubated and placed on Nexium for stress ulcer prophylaxis. That is an appropriate time to do it. The medication ended up being continued after discharge, and they have no prior history of further ulcers. What is it?
Medication
Someone
use
shout
without
it out.
indication.
Okay. So this is your drug use without indication. Meaning it was indicated in, it's like what we just talked about. Indicated in hospital, but they've been sent home. They've been continued on the medication at home, but they don't have a reason to be on it anymore. Does that make sense to everyone now? Might have been the way it was worded. Okay, next. Recent initiation of Bactrim, and someone calls the doctor complaining of a rash. What do you think this is?
Drug allergies.
Adverse drug reaction. So side effects, allergic reactions that you suspect. It doesn't mean they have to be confirmed. These are what are you suspicious for. Part of what you assess is the likelihood, but likely an ADR. Elderly woman on Medicare Part D. She's on several expensive medications, and she's in her donut hole. People know what the donut hole is?
Yeah.
Okay, thought you had that. So consequently, she's only taking some of her medicines every other day to stretch them out. It's the example I just gave you. So I put here failure to take or receive medicine. You could also make an argument for a secondary issue of subtherapeutic dose, because if she's not taking it, then she's not getting the right dose. But the best one is failure to take or receive. All right, type 2 diabetes, taking metformin, and the drug and the dose is the drug and dose of first choice in this patient population. So it's the right drug, it's the right dose. Despite that, and despite good adherence to lifestyle recommendations, their blood sugar still is not at goal. So from that list that I gave you on that first slide, what do you think? It's not,
Additional
someone was
therapy
brave enough
needed.
to say improper drug selection. That's not it, because it's saying that it's the right drug for this type of patient, it's the right dose, no contraindications. So it's not improper drug selection. Let's say, I will tell you, for example, metformin is contraindicated if someone's serum creatinine for a female is over 1.4, 1.5. So if she had a serum creatinine of 2, then it would be an improper drug selection. What were you going to say?
Additional therapy needed.
Yeah, this is one where it's my little quirky additional therapy needed. Everything's actually perfect. You just need another drug. Or again, it might get lumped into untreated indication. All right. So if you feel like you need more examples of those, like what I would do is create scenarios and quiz each other if you struggle with that. And then if you need me to create more scenarios, I can try to. But I think if you review what's going on in that tip sheet, you should do okay. So then finally, documentation. So we're going to talk a little bit about documentation and SOAP notes. As a warning, the SOAP note is the most common method of documentation in medicine, across all medicine. That does not mean that it's the only way to document. In pharmacy, people tried to do farm notes for a while. People are now doing what are called SBARs, Situation Background Assessment Plan, or I don't remember. SBARs were intended to really be for like communication of non-direct or non-patient issues, but some people are using SBAR notes as their ways of documenting. So we're going to do SOAP notes, but again, you have to have flexibility. But why document? And what to document? The key to remember is if it's not documented, it didn't happen. Document, document, document. If you ever want to have hope, once we get provider status, hopefully this year, definitely in May, if you ever want to get paid for counseling a patient, if you don't document that you counseled them, no one's going to pay you for it. If you don't document that OTC recommendation, no one's going to pay you for it. And if something bad happens and you haven't documented your decision making and why you did things, you open yourself up to legal action a lot more likely than if you documented everything well. You want to be precise and concise. And when you have official medical records, you never erase or scribble through. So if you're dealing with written records and you make an error, you do a single line, like a little delete, and you initial it, and then you rewrite what you need to do. Or an electronic medical record, once we submitted a note, we cannot alter that note, we can only add addendum. And that's because you never want to look like you're trying to cover something up. Okay? So, common elements of medical records. We've talked a lot about elements of medical histories, but if you have a medical record, and once again, my formatting is off from Mac to PC, you will often see different sections of a medical record, whether it's electronic or paper. You'll sometimes see a demographic page, insurance information, medications may be separate from immunizations, there'll be a section for lab results. Just know that often things are organized into sections. Progress notes, which is where the SOAP notes would go, are often their own little section. Usually each section and each page, every time something's entered, should be dated, timed, and have initials or the full name of who's recording that information. And when we get to the ease of electronic medical records, this is another example of a different system. A lot of electronic records have these lovely little face pages. So for example here, we can see our demo patient. You can see kind of the last few sets of vital signs. You can see when he went to the lab, some medications, and then there's usually hyperlinks to those sections or tabs along the top. So electronic medical records are wonderful for quickly and easily navigating between all these sections. Old paper systems are great if they have tabbed sections, and then there's the ones that I used to deal with. When I was in residency, that stunk. So just know that usually things are sectioned off into their own kind, and then they're chronological within sections, but they're not fully chronological. Does that make sense?
Mm-hmm.
Okay. So you have to flip around. So SOAP notes, again, most common way of documenting patient encounters. Lets people know what happened at that visit, what was your thought process, and it's good for reminding you of things. So for example, I might write my SOAP note, at next visit, make sure to help patient fill pill box. Well, that way I don't forget to do it. And again, as electronic health records, that's what EHR is, that increases. A lot of notes are being based on templates. So it's not even like handwriting anymore. At Coumadin Clinic, we had like a standard template, and we just used check boxes like, were they bleeding? Yes, no. Did they complain of this? Yes, no. And we just had to do the check boxes, and then it populated it into a note. And then you could further edit from there if you needed to. So, anyway. But if we're going to go old school, What are SOAP notes? So again, in a problem-focused encounter, the subjective, and we talked about what goes in subjective. In a problem-focused encounter, subjective information is usually going to be paragraph format without any subdividers. Versus in a comprehensive note, like that initial physical exam or a new doctor or the admission to a hospital, you'll usually see the subjective subdivided with subheadings. You'll see chief complaint, HPI, past medical history, blah, 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 blah. You always want to indicate your source of information, or sources. So patient came and data was collected from themselves and their wife, or themselves and their health records. You want to be clear and concise, and if it's a problem-focused visit, only include pertinent information. We're not going to worry so much in this course about pertinent information because you don't have the therapeutics background now to know what's pertinent or not. As you get into Therapeutics 2 and Therapeutics 3, they're going to give you a lot of information and then make you write a SOAP note that condenses it only to what's important. And then finally, it's usually acceptable in subjective sections to use sentence fragments and accepted medical abbreviations. It does not, you can do run-on, it doesn't have to be like perfect grammatically correct English from this standpoint of sentence structure. So that's subject. Objective, you're usually going to see in list or table format. Again, problem-focused encounters, you're only going to include data, labs, etc., that were needed to rule in or rule out issues. One exception is you'll always see vital signs. And then it can be helpful to show historical results. So if you're seeing someone for diabetes and you're listing their A1C, it might be nice in parentheses to put what was it 3 months ago, what was it 6 months ago, so someone knows trends over time. So that's your objective section. And I'm going to show you examples in a moment. Then we have assessment. So this is where students start to have the most trouble. But assessments are usually a numbered or bulleted list. And usually the start of the statement will either be the medical problem or the drug-related problem. Most common in medicine, people are going to organize SOAP notes by medical problems. So that tends to be what we as pharmacists do. In the medication therapy management models for payment from Medicare Part D, it's recommended you do it by drug therapy problem. But in our course, for the purposes of therapeutics, you're going to do it by medical problem because it's the common language everyone gets. So hypertension, blah, blah, blah. If you can, and again, you're not going to be held responsible for that in this course, but you would like to prioritize your assessment. What's the most important problem to the least? And the important thing, and this is what's hard, is you should never introduce new facts. You shouldn't list someone's hemoglobin A1C for the first time in your assessment section. You shouldn't state that they were in the hospital last week for the first time in your assessment. You shouldn't state they're on this medication or they're non-adherent to this medication for the first time in the assessment. It should have already existed. So I always think of a SOAP note as a funnel. You can put subjective and objective information into the funnel, and it can't come out of the bottom unless you put it in. So it can't be part of your assessment unless you... So you can make statements that interpret data, but you can't introduce new facts. And that's the hardest part of writing SOAP notes, I think, for students, is getting that variation of, am I introducing new facts for the first time inappropriately? Usually then what happens is after each problem name, there's going to be a short statement, and it usually minimally is going to say, is the problem controlled or at goal? What was the goal? So blood pressure uncontrolled at, goal is 140/90. If it's stable or unstable, this might come in like for chest pain. I think that they're having unstable chest pain. If it's not controlled or it's unstable, why do you think? This is where drug-related problems may come in. So, or our diabetes example, hemoglobin A1C not at goal of less than 7%, despite optimal therapy with metformin because the patient needs additional therapy. That's an objective statement, or that's an assessment. And then again, if the drug-related problem is present, what is it? So that's kind of what goes in your assessment statements. And then finally, plans. So again, plans are usually bulleted or numbered lists that follow your assessment. Sometimes you'll have the same plan, though, for more than one medical problem, so it's not always perfect. But it's going to include what are your drug therapy recommendations, so what drugs do you want to start, stop, or continue? And if you're going to start or change something, what's the dose, what's the duration? Any non-drug therapy? Do you need to do any further lab or diagnostic testing, either to further define the problem or for follow-up? And that gets down to like the physical exam that you need in the future. So after you change your blood pressure medicine, you may want to repeat blood pressure in a month. When is the patient's next visit? Who's it going to be with? And then finally, what type of patient education do you provide? And this is not a script of everything you tell the patient, but it's things like educate a patient on proper way to use their inhaler. Educate a patient on appropriate diabetic diet. Seems simple, right? And then finally, and this is just in 2 places, I'm just seeing where we're at. When you document, there are certain abbreviations you should not use. We as faculty try our best to avoid these as well, or at least I do. I'm not always perfect. But this is the official do not use list from the Joint Commission on Accreditation of Healthcare Standards. What's important to note is this is only a requirement in JCAHO covered facilities, which are hospitals and hospital entities. Meaning your family medicine practitioner does not have to avoid these for a prescription to be legal. But it is best practice to do it. And since eventually all doctors and PAs will train in hospitals, hopefully over time we get out of the habit. And a lot of organizations have further things on their list. This is the minimum. And JCAHO provides other recommendations. So if you look at it bigger, you cannot use U, big or low, for unit, or IU for international unit. International unit's my big one. I do it all the time. I do vitamin D stuff, and I write IU accidentally all the time. And what this list tells you is it tells you why is it a problem, and then what should you do instead. Daily, QD, no QDs. You should be writing daily, or no QOD, should be writing every other day. Now, we're still going to make you learn what these mean and test you on them because people are still using them. But trailing zeros, you shouldn't be using trailing zeros, and you should be using leading zeros when you're talking about drug dosing. Now, there is an exception, and it says that these trailing and leading zeros apply to medication-related documentation that's handwritten. And down here, that things like laboratory results where you need a trailing zero, that's okay. So it's okay to say an INR is 2.0, but you don't want to say give 2.0 milligrams of warfarin. And then the last one that's required is MS and MSO4 and MgSO4 magnesium. So something you need to be able to do for next week on the test. So if I give you a statement and it says, you know, what was the unallowed abbreviation and what would be the correct way, know this minimum list. You just got to know it. Other common things that people add are like the ears, like the AU versus the OU and stuff like that. But this is the minimum list. This is all you have to memorize. When you're writing, documenting in this course, these are the only ones you'll get dinged for if you use. Fair enough? Alrighty. So, this is, we're going to go, let me see where we're at. Yep, okay, we're going to run a little. So just to give you, and this is, again, on Blackboard, but just to show you what you have on Blackboard, is there is, again, I talked to you about the SOAP note tips, but there are sample SOAP notes on Blackboard. So I gave you 3 sample notes, what they might look like. So you can look through those on your own later. And then there's also a checklist. So when you do have to document later on in the semester, these are the things that will be on there. And sorry, I'm stuck over here. There's a couple, and they're just yes, no's. Did you do it or not? Or is it not applicable to the situation? The top 4 are just related to construction. So was it clear and concise, correct spelling, you avoided the do not use list, and is information in the right section? From there on, you know, does it have pertinent subjective information, pertinent objective information? When you get to therapeutics, it'll also say you avoid superfluous stuff, but, you know, which is this lacks extraneous, so that would be an NA for you. Do you correctly identify medical problems, therapeutic goals, drug-related problems? So this is for a full SOAP note. It's what we went over. What you guys, if you document, will likely be held responsible for is these items related to note construction, that you have the pertinent subjective and objective, and that within reason you can correctly identify drug-related problems. We're really going to be focusing on your ability to write subjective and objective sections and just a little bit of assessment in this particular course. We'll do a lot more with the rest next fall in my course. But this is here for you as well. So what I want to do now, and we may have to do some of it, well, you'll have 10 minutes to work on it. You can work on it on your own, whatever. But what I have next is a video. And this is actually, our students at Maryland had to do what's called OSCEs, where they worked with standardized patients for testing purposes. And this was a girl that, she didn't do everything perfectly, but she said I could use her video for educational purposes in the future. So what I'm about to do, and this is on page blah, 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 blah. You have room on page 9. No, I lied.
7.
Page 7. I'm going to show you the video. So what I want you guys to practice doing right now, most importantly, is take notes, just shorthand and scribble. If you were the pharmacist taking care of this patient, you're going to notice it's an OTC consult, and you needed to document what happened. You can't do good documentation while you're with the patient. You either got to remember or you got to scribble while you still look at the patient. It becomes a skill. So I want you to scribble down what you're hearing and take notes. Then what I want you to do is talk to a neighbor after I play the video. I'll play it a second time if we need to. But talk to your neighbor and compare and make sure you got everything. And then what we will talk about is what didn't. She doesn't do everything perfectly. So did you catch her asking anything incorrectly? Or do you think you caught her not gathering any important information, especially related to the symptom analysis? And at that point, we may kind of have to end our class session, but we'll have a plan for if you want more practice. But I think still watching and practicing jotting what you see. So let's go ahead and do that. Make sense to everyone? And we'll go from there. Hopefully the sound is still working. It is. And it's only like 2.
My name is Emily. I'm the pharmacist here. How can I help you today?
I came in because I'm having some really bad leg pain and nothing I can do has made it any better.
Okay. All right. Now, when did this leg pain start?
I want to say that it started about 3 days ago.
3 days ago. Okay. And is there anything that brings the pain on in particular?
3 days ago I was on a plane flight coming back from Madrid, and then 2 days ago it got worse because, I was like lying in bed doing some emails, and I noticed, I still have that pain.
Okay. Now, is it your left leg or your right leg?
Right.
Okay. So it's just localized to the one leg. And is there any swelling associated with the pain?
It feels a little swollen.
Swollen. Okay. And when you touch it, is it warm at all?
Yeah, it feels kind of warm.
And a little bit red. Okay. Is it red or no?
It used to be red.
Any redness, but it's swelling and warm. Okay. Now, how would you describe the pain? Is it a sharp pain, a dull pain, or?
Kind of a deep, achy sensation.
Deep, achy pain. Okay. And on a scale of 1 to 10, how would you rate the pain? 10 being the worst pain that you've ever felt before.
Right now it was a 5.
5. Okay. And do you have any other associated symptoms? Does it radiate anywhere?
No, just kind of staying in one spot.
Okay. And are you feeling any other nausea, any symptoms anywhere else?
No.
Okay, not associated with that. Okay, Mrs. Smith, it sounds like since you said that this was occurring, that it started when you were on your long plane flight, it sounds like you might actually have a clot in your leg. Sometimes when you go on very long flights, about how long was the flight that you had?
It was like 15 hours.
Yeah, so sometimes when you're just staying still for that long, the time the blood can clot in your leg, just from not moving around for a long time, and it's something called a DVT, or deep vein thrombosis is typically what occurs. Yeah, so it's important. I'd like you to go ahead and go to the emergency room. I think that would be best for you to be evaluated right away. Sometimes this pain, the clot can break off and travel to your lungs, and you can get something called pulmonary embolism, and we wouldn't want that to happen.
No.
So it's certainly not life-threatening. You're not in any immediate danger, but you're going to need some medicine that can be prescribed, some blood thinners that can be prescribed in the emergency room. Unfortunately, we don't have anything here at the pharmacy that can take care of that. But I'm really glad that you came in today and shared this with me.
Yeah, I definitely want to get it looked at.
Yeah. Are you able to get to the emergency room today? Okay. All right. I think that would definitely be your best option. I'm sorry that I don't have anything here to help with you.
All right. Well, I'm glad I came in and talked with you.
Yeah. Thank you. I appreciate you coming in and asking a question as well.
All right.
All right. Let us know how it turns out, okay?
I will. Thank you.
All right. Thank you.
So So one thing I learned in 8 years of having students work with standardized patients for testing purposes is you get nervous and giddy, when probably in real life you wouldn't be quite as giddy and upbeat, but overall she did a pretty good job. So I think from time's sake, why don't you go ahead, just compare a couple things with your neighbors, like do you have the same information?
Like
More
3 days the
importantly,
plane, right, like Romans.
what did she inquire about incorrectly or maybe not ask about that you would have asked about?
Yep, she asked leading questions.
She was told the class ended at 5, not she thinks it.
She thinks that it does, but it doesn't.
Well, okay, well, so I'm sorry that we're not done yet. I would have cleaned up a little early, so give me 5 extra minutes.
Sure.
I'm sorry, next time I know, I was told 5 o'clock, and yeah. So let me just tell you a couple things I noticed. I heard lots of good conversation. In terms of information that was collected, one thing she clearly did wrong is she used the pain scale wrong. She said pain on a scale of 1 to 10, with 10 being the worst you ever imagined. So she did everything wrong. Or no, she said the worst you've ever experienced. It should have been 0 to 10, 10 being worst you imagined. So she did the pain scale wrong. Other issues, she was a little all over the place, and that comes with time. We already talked about being giddy. I would have asked, like, associated symptoms, and this comes with time, but, the danger of DVTs is that they can cause PEs. You learned that in pathophysiology. So I would have specifically asked this patient, are you having any chest pain or shortness of breath? Because if she said yes, that might change my decision to, you need to get yourself to the emergency room, to saying, I'm going to call 911. Because a PE can be more immediately life-threatening. There's lots of other little things she could have gathered. Maybe a better temporal history here and there. But the reality is, she collected enough information to probably make the right judgment. Now, did she really relay that in the best way? No. She made it sound like a definitive diagnosis, and that was her nervousness. I know this student in real life would not have said, you have a DVT. She would have said, based on everything you're telling me, I'm very suspicious that this could be going on, and so you need to get it checked out immediately. So this is the plan, And so that was the right call in this case. So those were some of the kind of the major things. From a time's sake, this is what we're going to do. And again, you got to give me 4 more minutes. One thing I want you to do later this week, over the weekend, is take this and now try to write a SOAP note about the encounter. Like if this was you and you had done it, based on what you did see, write a SOAP note about it. What I will do is I will post a key for that to appear, say, Sunday night. Give you a couple days that if you want to work on it, you have to force itself. But then you can see what would my SOAP note have looked like. And I also made notes on that about other things that she could have collected, etc. Okay. Number 2, if you want practice getting a symptom analysis, there is an activity we didn't get to towards the final pages of your packet where you could partner up with someone. They would have a chief complaint. You could ask the questions, and they would have answers to give you. So, and that's, so if you want to practice taking a symptom analysis, you can do it. That was always a planned only if we have time left over. What I need you to do before you leave, because it also proves that you were here, is the very last page is your muddiest points. So I need you to put your name on there. And I believe I have it as, I want you to write down, what did I tell you? Up to 3 concepts that are still really confusing to you or that are still hard for you to understand, kind of your murkiest points. Or if you feel really good about everything, tell me at least one thing that was interesting about today. Because what I'll do is I'll look through those. It proves you were here from your participation attendance. And then also, if there's a lot of common themes on what people are confused about, I can do some additional things to clarify information through Blackboard and by talking to you guys. So once you fill that out, you can get out of here. Sorry that I was misinformed about the stop time of the course.